Hello, everyone, and welcome to this session. It's my pleasure to welcome you here. For those of you who are here live and those of you who are virtually, good morning, good afternoon, good evening, wherever you may be. My name's Mahmood Bhutta. I'm an ear, nose and throat surgeon by background, but I've had a long-standing interest in sustainability, and I work at Brighton and Sussex Medical School, who are kindly hosting this event on behalf of the COP conference. So that is based in the UK, and we have had some interest in developing research that underpins sustainable healthcare. And by that, we mean the contribution of healthcare to the sustainability agenda. Many aspects of healthcare impact on the climate, and we know that the NHS and health systems around the world are thought to contribute between 4 and 5% of the entire carbon footprint of a country. So it is important that healthcare not only advocates for the health effects of climate change, but also tries to get its own house in order to make healthcare more sustainable. And that's really what the aim of this session will be. And I'm very glad that we've got an illustrious group of presenters from across the globe to talk to us about the various aspects of how we achieve that. I'd like to start with a few little housekeeping rules. So just to let you know that this session is being recorded, and so will be available on our website, which we'll put into the chat shortly for viewing later, but only the panelists will be visible and nobody else. There is a Q&A function, so please do put your questions and answers into the chat. We will take Q&As from the floor at the end of the session. I can't promise you that I will answer every question, but we will certainly try. And if you're able, you can upvote some questions that you think perhaps should be given priority. In terms of other aspects, there are some social media outlets as well, and we'd encourage you to use those, and those will be put into the chat as well for you to look at. And finally, for those of you who may have problems with language or with hearing, there is a closed captioning service available as well. So without further ado, I'm going to introduce each of our speakers ahead of their asking them some questions really around this. And so my first...
Apologies, everyone. We seem to have lost Mood, so we'll just give him a second to see if he can rejoin, and then we'll carry on with introducing our panel. In that case, what I will do is I will go along and ask each of the panels to introduce themselves. So up first on my screen, I have Dr. Forbes McGain. If you could introduce yourself, please.
Hello there. I hope you can hear me from Australia. Thanks everyone for listening in, and thanks very much for the organisers for including me in this. So we've heard a little bit of the scene there from Mahmood Bhutta, and thinking about what was it that got me involved and why environmental impact of healthcare matters. I actually grew up on an avocado and macadamia farm on the east coast of Australia. On the subtropical area. And so just a little aside there, on the farm, waste was minimal and nature was always close. Now I work in intensive care and anaesthesia in Melbourne, and here at work, you know, excessive waste occurs at every level: energy, water, plastics, you name it. It's there to protect patients, but at the same time, you do worry that when you're dressed in oil, as I was today in intensive care and going through 20 gowns, thinking about the unsustainable nature of what we're doing. And so although some progress has been made, I'd like to just reflect on a few points that probably are reasonably impactful, that could be a message to all of us to think about how we can lead in ways ahead here for improving healthcare sustainability. And I'll talk about the micro, meso and macro approaches, which have been propounded previously by others. But in terms of the micro, I think that focusing on hotspots is important. So thinking about anaesthesia, which is a really big one, and lots of gases have a high carbon footprint. We can think of metered dose inhalers from our respiratory physicians and the GPs changing asthma medications. We can think of nephrology, so all the dialysis, the equipment that's being used for that, all the things that surgeons use that are single use. And then you can even think about we don't forget our good physicianly friends, and think of pharmaceuticals and stewardship that can be done there as well. And really importantly, nurses. So nurses have a role across the spectrum here on what they can start to think to do to improve the situation for not just one group, but for all groups within healthcare, within hospitals, which are really energy and waste hungry parts of the world. So I think that focusing on the relatively substantial is important. So although recycling is fun, and I've been involved in that for 15 years now, it's not really the big part of the story here. It's focusing on those really points that matter. And I think that renewable electricity really matters in making things reusable equipment better. So in other words, having a renewable energy source is quite important. So aiming for the relatively easy first versus the difficult. So the easiest, it's quite surprising. I remember being involved in transforming with the anaesthetic and other teams, the use of reusable equipment away from disposables. That was actually much easier than changing the coffee cups in the cafeteria. That's actually a harder thing to do, surprisingly perhaps. I think considering also what is feasible from a solo practitioner's point of view, whether it be a solo nurse or physio or doctor, reducing the amount of syringes, etc., that you're using, reducing the amount of equipment, that's all important. But I think also collaboration is incredibly important here, and other processes to change things. So I think that all of those factors are important. I think also you can think about what matters sometimes to certain groups, which is quantitation and numbers, for example, with anaesthetic gases, but as opposed to what is qualitative and requires a bit of charisma to change things. And examples of that, for example, in intensive care would be, well, we don't actually need numbers to, say, reduce the amount of bags that are being used for renal support or DVT prophylaxis, mechanical devices and things. They can all be changed and reduced whilst not affecting patient care, but they may not need as much data as, for example, comparing carbon footprints of different anaesthetic equipment. So I know I've focused a little bit on anaesthesia there, but I do think I'm trying to give the story that all of us have a role to play in trying to reduce the carbon footprint of healthcare. And I'll just mention with a few other points about creating a hospital sustainability working party is incredibly important, led by hospital executive, and along with that, encouraging the employment of hospital sustainability officers is actually vital, because they're able to free up busy clinicians' time, like my own and other nurses and doctors, etc., and they pay for themselves quite quickly because they're able to, their wages can be spent looking after and reducing energy consumption, for example. Joining medical, nursing and other healthcare environmental groups, here in Australia, Doctors in the Environment or Climate and Health Alliance, but there's many other groups in other parts of the world that have equally important roles to play. And I think agitating at the macro level for medical, nursing colleges, societal involvement, British Medical Association, just to name one of many, is incredibly important, as well as being part of national hospital accreditation requirements, and patient advocacy groups here is going to be really important as well. So I think they're the important points that I wanted to get across pretty quickly to the team that are listening in here, to say you have advocacy, you have agency, we can change things. Collaboration is incredibly important on the road and the pathway to sustainability. So thanks for your time, and I'll move on to the next speaker.
Thanks so much, Forbes. I'm sorry for that technical glitch right at the beginning. I'm back in. So thanks for stepping in. Forbes, perhaps I can ask you, it's great to hear the work that you've done within your organization and also trying to spread the ideas, but people say the behavior change is the biggest barrier to making our work more sustainable. What have you felt? Is that the biggest barrier to change, or do you think there's other barriers?
Yes, I think that, in fact, there is a list of barriers that exist there, but in a way it is ourselves that are the barrier, like it was ever so, or ever thus. Being more imaginative and curious about changing the way we do things, I think is incredibly important. In healthcare, the status quo is important because you're avoiding patient harm. So we are perhaps more risk averse in healthcare than in many other fields of the broader economy. And I think that we need to balance always having patient care, number one, but also focusing on planetary care in a sense, or the broader societal care of not wasting as much, and working with all of our different streams within nursing and medicine to change the way we do things. So I think that challenging the status quo and educating ourselves about carbon hotspots or about different fields of medicine and nursing, etc., that might be problematic from a healthcare point of view, I think is really important. I think that also the hierarchy of medicine in particular, but also nursing to a degree, is important to challenge at times. I think juniors can work with seniors by identifying just one or two seniors that might be able to help them in this. And I was thinking about, like all you really need is one surgeon, one charge nurse, one physician, one GP, for example, who are willing to get involved in this, and you can actually make enormous change, even if it's the juniors who are trying to make that change and not so much the senior. I think infection prevention and the teams there are going to be incredibly important to working with this and having leadership there to work with that conflict, that natural, and we identify there's a natural conflict between infection prevention and environment, the broader protecting the patient and the planet. So sure, I think resisting marketing and also working with government is going to be important as well. Thanks. Okay,
Sorry, yeah, I think we better move on. That's great. So I think there are lots of complexities there. So Chantelle, I don't know if you're back on. I'm sorry, we've obviously had technical issues on several points. Are you here with us, Chantelle? If so, I can introduce you.
Okay, great. Can you hear me now?
Yes, we can hear you. So Chantelle, as I was starting to introduce, and I'm not sure whether how much of that you heard, Chantelle is a research fellow at University Hospital Sussex and currently completing her PhD at Brighton and Sussex Medical School alongside me. And she's particularly looking at how we can reduce the environmental impact of common operations. Was also a founding member of the Royal College of Surgeons of England Sustainability and Surgery Working Group, and has really pioneered a lot of evidence in this sphere. And I think, to my mind, having evidence of what we should do should be the fundamental basis for us moving forward. So Chantelle, we'd be grateful to hear your thoughts on this, on the research and the evidence agenda.
Okay, great. Thank you ever so much. And welcome to everyone from the WHO Health Pavilion at COP26. My name is Dr. Chantelle Rizan, and I'm in the final year now of my PhD, looking at the evidence basis for reducing the environmental impact of common operations. And if we step back and we look at the net zero transition and the pathway to sustainable healthcare systems from the greener NHS, we see that actually over half of that roadmap is reliant upon research and innovation, low carbon alternatives, low carbon patient pathways, and supplier alignment with the greener NHS ambition. And research is only really explicitly mentioned in one of those areas that I picked out, but I would argue that it's absolutely essential that we take a strong evidence-based approach in actually informing that pathway. And that's especially given that we know that across environmental accounting, there are often counterintuitive findings. And so we need that strong evidence basis to make sure that when we're making changes towards sustainable systems, that there's a true net benefit to our environment. So I'll be describing the three principal ways that I feel that research can add value in terms of our journey towards sustainable healthcare systems. And in talking about research, I'm talking about the highest evidence level, which is our life cycle assessment, which can be used to evaluate the environmental impact of a given healthcare product right through to healthcare systems. Many of you will be more familiar perhaps with carbon footprinting, which is a subset of a life cycle assessment, or LCA, focusing on the greenhouse gas emissions. So firstly, life cycle assessment is a really useful tool in evaluating and identifying hotspots and seeing the areas within a given system that make the biggest contributions. And for example, within my own research, I look at the most common operations within England, and I look at the underlying processes and the hotspots there. And I can see that actually across the operations that I look at, 60% of those impacts come from the production of the single-use items as well as their packaging. And that's then followed by 20% from the decontamination. So that's sterilization of the reusables, and 8% from the waste. And so from this hotspot analysis, we see those are three areas that we really need to target. Now, that hotspot analysis can also be done at an individual product level. And I found that across my data set, there's just a few items of equipment that actually make the biggest impact. And it's actually 22% of the individual products that predict 80% of the carbon footprint. And that's a really nice illustration of the Pareto principle that you might be familiar with. So that's hotspot analysis. Secondly, life cycle assessment can be used when it's used consistently, using a consistent methodology to compare the environmental impact of different products. And within my hotspot analysis of removal of a gallbladder, I identified that there were just 3 single-use laparoscopic pieces of equipment that contributed to 18% of the impact of that operation. And so actually, through life cycle assessment, I modeled hybrid equivalents that were available on the market, which are predominantly reusable, finding that actually reduced the environmental impact by 75%. And thirdly, life cycle assessment can be used as scenario modeling in order to actually look at optimizing underlying processes. So sterilization, I mentioned as a real key hotspot. And actually, I found that you can reduce the impact of that by around 1/3. And that is through changing from supplementary items into preparing these instruments as part of sets, and from actually optimizing the loading of our decontamination machines, using low carbon energy, and also recycling of our sterile barrier systems. Waste was another process that I found that we could have a 50-fold impact in terms of the carbon footprint of the waste, depending on the waste stream that we used, with highest impacts for high temperature incineration as used for clinical waste, and lowest for our recycling. So in summary, that's then we can use the research essentially to identify those biggest areas that make the biggest impact in terms of our environmental impacts. And we can then use the life cycle assessment, more detailed methods to compare between different products, and also to look at optimizing systems. But the academic field of sustainable healthcare is really in its infancy. And to date, at my last check, there was only around 130 published life cycle assessments globally. And there's just a handful of researchers in this field, many of whom are actually on the panel today. And so really, we need to be calling on those that fund research to actually to fund this sort of work. And we need our academic medical journals and conferences to actually support this. And finally, we also need education for our healthcare professionals to improve their carbon literacy such that they're able to access this information. Over to you, Mead.
Thanks so much, Chantelle. Yes, I mean, it's very, very important, I think, that we understand where a lot of this work comes from, a lot of our carbon footprint and life cycle harms come from. So it also guides us to where we can direct things, exactly as you've said. But I suppose the question I'd have for you is, you know, many people will be sitting here saying, well, and I get approached of, can we carbon footprint this? Can we carbon footprint that? And I think it's quite a complex thing. So is it more about some principles that we should be following? And then are there any cheats? Are there any easy ways for us to understand how we can sort of measure the environmental impact of things that we're doing?
Carbon footprinting, and especially life cycle assessment, is a really resource intensive process in terms of time and expertise, and sometimes quite expensive software. And so really it is about using those generalizable principles as you describe from existing literature. We absolutely know that when we talk about sustainability, the #1 priority has got to be reduction. And if we don't use something at all, then that is of course going to be better than looking at a low carbon alternative. Across the existing evidence, we know that reusables are better. There's a few exceptions where we use coal-based electricity for the sterilization, but really wherever reusable alternatives are available, the majority of evidence points in that direction. And also using those circular economy principles such as repair and recycling helps us to maximize our resources. There are a few shortcuts, as you mentioned, in terms of actually determining carbon footprinting. There are simpler methods using the financial cost as a proxy. That is not necessarily sufficient for the more nuanced work. And I'm developing actually at the moment some novel methods that might be helpful for the clinical context to actually get a rough sense of the carbon footprint based on some easy to measure metrics such as weight, to identify that rough area in which the carbon footprint might lie for a given procedure, for example, and also to point out those hotspots. And so watch this space for some novel methods coming up.
Thanks so much, Chantelle. Okay, so I mean, one of the things that we've heard here is about the idea of reduce as a guiding principle. And I think one of the things that we can look to is actually how things are done where we have low resource settings, where actually reduce is a necessity because of the lower availability of resources. So I think I'd like to move on now. It's a pleasure to invite Cassandra Thiel and Dr. Venkatesh. So Cassie is an assistant professor in the Department of Population Health and Ophthalmology in New York, and her research has really looked to quantify and looked at how we can reduce emissions associated with healthcare activities and medical products. And I know that you spent some time working with Dr. Venkatesh in India, who's the Chief Medical Officer at Aravind Eye Care System in Pondicherry, who's got a special interest in low carbon eye care. And it'd be really interesting to hear from you how things are done differently, perhaps in a low resource setting, and what that means for our carbon footprint. Cassie, over to you first. Thanks.
Sure. Yeah, thank you so much. Yeah, so I got into this as an engineer working on life cycle assessment in other industries, and I had done some of my doctoral work looking at hysterectomy and birth procedures in the US. And it became very clear to me the more time I spent in a clinical space that a lot of Western medicine is kind of all the same, that it looks like we have a lot of disposable materials, and that seems to be where a majority of our emissions are originating. And so I felt like doing more and more LCA studies in the US may not get us to the place where we can actually really significantly reduce the footprint from clinical care. And in conversations with some colleagues, I learned about Aravind Eye Care System and their approach to especially cataract surgery, which is one of the most commonly performed procedures in the world. So I had reached out to them and fortunately was able to conduct a study there and able to compare their carbon footprint with the carbon footprint of phaco emulsification, a common approach to cataract surgery based in the UK. And what's fascinating about these resource constrained settings and areas like Aravind, where they're really trying to be efficient with the resources, they're trying to reduce the cost of care, they've really found great ways of optimizing all these materials and resources that are needed. So in the end, the calculation was that Aravind's carbon footprint was about 5% of what it was in the UK for the exact same procedure, and their outcomes are great, well documented. So we know that this is possible. I'll hand it over to Dr. Venkatesh to kind of talk more about what Aravind is doing.
Thank you, Casey, and thank you, Professor Mood, for having this great panel. So Aravind was an organization which started 45 years back, and now we see close to 15,000 outpatients every single day, and we perform 2,000 surgeries every day, which is like 4.5 million outpatients a year and roughly 500,000 procedures. So this volume was built over a period of time with a very clear mission to eradicate needless blindness. So we were always looking at the patients first. So we had a lot of unconventional ways of getting patients into the system. We said reaching the unreached, or looking for the non-customers in the form of outreach activities, primary eye care centers or the vision centers, which was kind of functioning in semi-urban rural areas where there were no eye care, and they could come to the secondary and tertiary eye care centers for other specialized procedures. But 85% of the treatment could be given in that setting itself, so that they don't have to travel to a hospital. They don't have to do multiple visits. In the same time, our system was kind of non-appointment system. Patient can walk in any time between 7 to 4:30 and register and have his examination done. And we tried to close the loop also on the same day. For example, if somebody needs a medicine or glasses, the glasses would be even made and given within a couple of hours after the testing. If he needs a laser or a surgery, for example, a glaucoma laser or a diabetic retinopathy laser, and if he's already prepared, the laser would also be completed with the investigations. So that's where we constantly looked at evolving our efficiency and also kind of training our team to close the loop on the same day. When it comes to cataract surgery, like what Casey said, we do close to 400,000 cataract surgeries of the total 500,000 procedures. That's a pretty high volume for any standards, which is almost 40% of what the state of Tamil Nadu does. We do it in one particular system. So where we are constantly again looking at efficiency and kind of reducing and of course kind of recycling a lot of waste and things. But How do we reduce is again, Casey did a lot of work to find out behind it, but we were doing it historically, and we were doing it not because resources were less, because we wanted to give the best to the patient, whether he was paying or free, we wanted to do the best to him. So we thought we can do that by only giving it in a lower cost. So we had our own manufacturing facility called Orolab to manufacture lenses, reusable pharmaceuticals, and we carefully kind of continuously used a lot of things. Like a pharmaceutical drug, a bottle will be just thrown out at the end of the day. Things like your gowns and attires will be kind of autoclaved, washed, dried and autoclaved at the end of the day. Surgical instruments will be flash sterilized in between cases. So each surgeon will have 2 tables and he'll be operating one after the other so that you can do 7 or 8 cases in an hour. So all of this, kind of reducing the amount of material you use, and also kind of recycling a lot of things in between by flash and full sterilization, and also carefully segregating waste at source, which again, we learned a lot of during Casey's work, but we do meticulous waste recycling. So all this at the end result was kind of helping the patient. So we were also aware that we are friendly to the planet and we are kind of making profits also. Thank you.
Thanks so much. I mean, it's really inspirational to see how that you can do these things. And I know that you've published some data as well on your infection rates, for example, which are actually lower, I think, than we see in that high resource setting. So it actually turns the whole idea on its head. We have this issue, I think, possibly where certainly some health systems won't necessarily be paying for some of these products, and we develop these systems that use, whereas you've shown that very much we can do it on a much more economical scale, economic both financially but also to our planet. But I guess one of the questions I have is in that many lower resource settings, people tend to see things done in higher income countries as something aspirational, something they should be looking to achieve. I mean, clearly you don't believe that, and that's great, but how do we reverse that mentality?
I think it's the more the evidence which we give, I'm sure it'll give a very clear path to whatever be, whether you are resource constrained or you have all the resources. And I think people who have all the resources are the ones who are really worried about the change. I'm sure, because once I think that thought process comes, things will definitely change. I mean, there are plenty of evidence, like what you said rightly, our endophthalmitis rates are 1/4 or 1/5 of what happens in Western standards with whatever we are practicing now. So I think it's only how we kind of play with the both governmental and the other associations to get certain things done. I still remember a UK-based ophthalmologist saying, iodine comes in 500 ml bottle and you use 3 ml for cleaning the eye, and the rest 497 ml goes into drain for every patient. So who is responsible for that? I think with that question, I'll end.
Thank you. I don't have an answer for you there. So I think is a very well made point. So, I mean, I'm going to bring in here now Fiona. Fiona, you are a public health physician by training. You've previously trained, previous roles have included being Deputy Chief Medical Officer for England and WHO Director. So you're clearly on the public health agenda. You've also been in this game for some time. You published in 2009, I think, the Health Practitioners Guide to Climate Change, and you're now chairing the Sustainable Healthcare Coalition, which brings together industry and the public sector. So, we have the people who are making the products and feeding what we need. So I just wonder what your thoughts are on how we can bring these ideas together, the industry and effectively the consumer or the user of these products, healthcare and patients, to sort of realize sustainability.
Thanks, Mood. And as you said, I've seen the system from every which way. I think what that has really taught me is that if we want to solve a system problem, then all the players in the system have to work together to come up with the solutions. And as a coalition, we were formed about 10 years ago because the NHS team at the time realised that the supply chain was a huge part of the carbon footprint, about 2/3 of it, and about 1/3 of that is related to medicines and devices. And the challenge we were set at the time was to come together and first of all come up with the first global greenhouse gas footprinting methodology, but also the care pathway methodology. And colleagues like Cassie were great in helping us make that happen. But in the end, I think, as Chantelle and others have said, this isn't just about measurement. At the heart of this really is what we're trying to do is design environmental impact out of the system, and to use our understanding of measurement to really do that. Because, what we've shown in all the case studies we've done, which have proved that it is possible to change, is that, health outcomes can be improved at the same time as you reduce costs and at the same time as you reduce environmental impact, so that we know it's impossible to do that. But we also know that what we have done for years is chosen to ignore environment. What we need to get to now is a situation where environment is part of every single decision we make in the healthcare system, from the top to the patient care point. That's what it's going to take, and that's a huge change. So I think when you're thinking about how do you work with industry, then what's going to make a difference? Well, the first point is, how do you incentivize that change? And I think one very big lever is procurement, shopping, how you buy kit, and how you set the rules for purchasing is really important. There's been some great work that's been done by UNDP and Healthcare Without Harm on their procurement system, which is being launched later in the year. But the NHS in England has also looked at that in their Evergreen framework, and they're now requiring all suppliers of the NHS to be net zero by 2030, but also to weight decisions around buying kit to include environment. The challenge, though, is how we really make that really meaningful in the system, because until we change the market incentives, and that when you produce a product that environment really counts, the system's not going to change. The second thing, I think, is that we also need to think about how do we inspire people to change. And how we inspire people to change, I think, is really unleashing people's imagination. Because knowledge can only take you so far. What we're really talking about is, how do we imagine a different world where different rules exist, and how we can do things differently and do different things. And what we learned from setting challenges for industry is that actually when you do that and you work very closely with clinicians and patients, you can unleash all this energy for change and really come up with some different solutions. So I think that's going to be critical for solving problems. But I also think it's important to go, if you like, where the action isn't. So Richard, who will be speaking later, and I have championed some work looking at a big part, we think, of the footprint of industry, which is around clinical trials, to look at research and development. We think that that's going to be quite a large part of the scope, and a study produced about 10 years ago showed it was probably about a third of the footprint of a country like Bangladesh. So we need to go there. But I guess finally, what we need to think about is, I think what each of the speakers have reflected on so far is that we are also all part of the problem, and that this is about mindset. And when I look at other industries and sustainability that I work with, industry has often championed change. And I think that in healthcare, we have had this real difficulty with working with industry, that sometimes we don't have that open mindset of really wanting to work together for change. And that is what we need to engender, because I think we need to move from a situation where we are putting a lot of energy into having fights we don't need to have, but we need to put it on solving these problems and working together to get a different system. And I think each of us needs to have the power, as Forbes was reflecting, to know that we can change, and that, if we demand different healthcare surgeons, if patients are more aware, if the system rule changes, then we can do this, and industry will respond because it responds to customers. That's what it's always done.
Thank you, Fiona. Yeah, that's great insight. I mean, I completely agree. We need to work together, because they need us, we need them. So there are definitely companies out there that I think seem to be heading towards the right thing, but there are also there's also been some issues. I mean, I can tell you, I was invited by a major supplier to the NHS to talk at one of their conferences when I insisted that I would speak about the idea of reduce and reuse. Their executive board decided they no longer wish to invite me. And that is a bit worrying to me. So I suppose there is this fundamental conflict between the idea that you need to sell products, and we as sustainable practitioners should not be buying products unless we absolutely need to. We've seen that from India, and we've seen that from Chantelle's evidence. So I guess, how do we resolve this? And are there companies out there that are prepared to reduce their sale instead of some of the companies that seem to be frank, greenwashing some of these ideas?
Well, I mean, I think what you've reflected is that, you know, we all would rather have less care. I mean, I hope in my lifetime I never need to go anywhere near a surgeon again, but the reality is that I might need to. And when I do, I really hope that they're going to be practicing in a green way, as you've reflected. So I think, you know, we all would prefer prevention to care. But I think we then need to realise just what the challenge is. And that's, you know, I think for the industry as a whole, the transformation that's required is huge. And that does challenge existing business models around, you know, how are you going to do business? How do you look for value in different areas? For example, in digital services, alongside products, there are all sorts of ways that people are trying to reduce impact at the same time as improving outcomes. And I think that's a transition that we need to go on. There are certainly many companies who are innovating in this area, as you well know, because I know that you, Chantelle, and others work with them to try to prove that there is less impact by doing things differently. But I do think that we need to realise that there isn't sort of some evil force over there, that actually this is a co-conspiracy, that we are all contributing to this problem because we have designed a system that's different. I mean, I'm ancient enough to know, because I trained in the 1980s and did my surgical house jobs then, that, you know, the world where you had single disposable instruments didn't exist then. It just didn't. And so we could do things differently, just as we were hearing earlier. So I think, you know, yes, industry is challenged. Yes, industry needs to change. It's not just within healthcare, though. I think capital markets will make a difference. So yes, we need to work together, but, you know, business models do need to change as well.
Yeah, so I guess the point you're making is we've, to some extent, created this business model, and it's up to us as well to make those changes. And this is perhaps one of those few instances where we can actually talk about the good old days, and they really were the good old days. So
they were different.
Yeah, well, some aspects of the good old days. So I think you brought forward there the idea that we all need to take responsibility, and perhaps one of the things that we're not really doing is having the knowledge to take this forward, or the personal responsibility. And one way of course to deal with that is through education. So our next speaker is Francis Mortimer, who's formerly a doctor in training in renal medicine, and then moved to become the medical director of the Centre for Sustainable Healthcare, an institution that's been there for well over 15 years, I think now, arguing for these changes. And I was there when it was set up. So she now works to integrate sustainability into healthcare culture, education and practice, and she's developed a framework for incorporating sustainability and quality improvement. Francis, it'd be great to hear about your experience in this field.
Thank you very much, Mood. Yeah, education is obviously critical, and I think one of the important things to think about is it's not just educating people to roll out changes that we've devised that are ready to go. We actually need the workforce to help co-create the changes that are needed, and so we need to think about education as being empowering to people to take things forward in their own setting. I think part of that is obviously raising the baseline level of awareness, and the baseline, and it's actually not a huge amount of knowledge that you need to get across to everybody. It's really the fundamental principle that environment and health are intertwined, and that this is indeed a health issue. And I think there is, as Chantelle was alluding to earlier, a degree of carbon literacy that we need people to have, so that they have a sense, in the same way that we can, you know, we have a sense that, you know, $1 is different from $100, is different from 1,000 or 1,000,000, that we can have that sense about where the carbon hotspots are in our processes and our products. But that's actually not a huge amount of knowledge that needs to get to everybody, and it is eminently achievable. I think it can be integrated across courses that healthcare professionals in training, but it can also be delivered, you know, quite successfully. We're finding with mass open access online training. Then, of course, there is a need for the actual skills to take these things into practice. And I guess I would divide these into sort of technical skills about, say, things like the practicing differently, like being able to, for example, empower patients and help them make make decisions about their care, and which is an important element. So there'll be technical skills around use of, say, local anesthesia or whatever it is. So those things, I think, can be integrated into training. And one of the most successful things that we've found is integrating into quality improvement training. And that's because quality improvement is a method for making change in systems, and change in systems is what we need to do. So, and it's also an existing part of training for most health professionals, and it's spreading across to those groups now that haven't previously had to do quality improvement training. So rather than creating a whole new curriculum around sustainability, if we can integrate it in, if we can align bits of training and practice to deliver sustainability, we can do it without massively expanding the curriculum, and it can actually be very powerful, that process of reframing. And one of the great things about working, we've got a project which is in the UK reaching out to all different institutions that are teaching quality improvement, and giving them tools and showing them how you can integrate sustainability into that. It is a way of taking it from the core committed people out to the mainstream who may not have thought of it before, and they're actually it's been incredibly well received. I think people just think, oh right, okay, yeah, I can do this, I can see how this can be done. And then the student evaluation that we're getting is also really impressive in that it's showing that people feel a sense of empowerment and ability to bring about change, and that they have confidence that they have some of the skills to get started on that. And interestingly, when we're starting now to look at the correlation between the different outcomes from teaching and what changes get made in practice, and the changes that people are making in practice has a greater correlation with people saying that they have confidence and skills than it does with their motivation to make change. So we need to move from telling people that there's a problem and this is what the problem is, to giving them some of the skills to act on that. And then finally, I think the other big element of education that we need is around leadership, and we need to engage leaders to help them to reframe this. We need things like fellowship programs or blended learning or ongoing programs where we support people to develop this and take it embed it in systems and learn from one another as they go. So I guess those were the three major approaches. I think the sort of mass education to everybody, integrating across other areas of the curriculum, and then developing leaders, whether that be through fellowship programs or board level training and so forth.
That's great. Thanks, Francis. So, I guess come back to one of the points that Fiona and Forbes have raised, that actually we need everybody to be doing this sort of thing, and everybody on board. I mean, we could argue that those who join your education programs are perhaps the converted, but to create change, we need to reach the masses. And some argue that the majority are not ready to make that transition, that feel change in the way we do business. I mean, I don't want to be pessimistic about it. I've been incredibly enthusiastic, I'm sure you have, over the last few months in seeing that change coming. And there's so many people really enthusiastic and converted that we need to do this. But nevertheless, there will be a lot of people that we need to educate and change behavior. So how can we engage the people who aren't on board without necessarily alienating? Because we need to bring them on board. We need everybody to be part of this.
Well, I think one of the really important things for doing that is aligning sustainability with the core mission of healthcare, which is to care for our patients and to do a really good job and get the best out of our resources. And I think when we start to do that, it doesn't become about, how somebody got to work that day. It's about how they can do a really fantastic job at work. And I think that people are motivated by that. And when you frame it in that way and you get in and you integrate it across the work that's being done, people come on board. And actually, if people are empowered to take action, that feeds back into their motivation, because one of the things that's really demotivating is just feeling that you can't make a change, and that the system's too big, and then you feel culpable but powerless. And I think that leads, nowhere. So by changing that and then giving people the tools to actually make a change and make it part of core business, I think we absolutely can make it something that reaches everywhere throughout the system.
Thanks, Francis. Yeah, I completely agree. And I think we're fortunate in the UK that healthcare providers and hospitals, for example, and all other health providers have to have a green plan by January, which means that it requires the leadership of those organizations to engage with this, which hopefully will enable all of those who really want to make a difference, hopefully all of us that want to make a difference, to feel empowered to do so. So that's fantastic. And I come back to the learnings from India, that we don't need to think that there is a compromise in patient care when we're changing systems, because we have clear evidence that's simply not true. So I guess one of the things that we also need to do is, obviously, we need to work together. It's still, as Chantelle said at the beginning, a relatively small number of people that are working on this in terms of building the research and those sorts of things, and the education. And we need to spread word further, and we need leadership. We need institutional leadership. So I'm going to come now to Richard. Richard is chair of the UK Health Alliance on Climate Change, which is an organisation that brings together some of these institutions to work together. Richard was also best known for his time as editor of the British Medical Journal. So Richard, I was going to ask you, how do we build this, these collaborations across institutions within, say, the UK, but also further afield, so we all sing from the same hymn book?
Well, thanks a lot, Mood. Before I answer your question, I just want to give a description of what it's like here for those many people who've probably never been to a COP. I've never been to one before, and this is my first morning, and it's kind of completely bewildering. So we're here amongst we're the health pavilion. There's about 80 pavilions. There's all sorts of noise and hubbub. Over here is the Congo Basin and African Global Challenge. Just there is the Senegal Blue Carbon. Saudi Arabia is just there. The Green Climate Fund is just there. The British Council is just here. There are screens everywhere and people bubbling around. And then there's an audience in front of us, all wearing masks, all on their phones or laptops. I hope they're listening to us, but I'm not absolutely sure they are. And the other point I wanted to make when we're talking about health systems, if you look at the Lancet Global Countdown publishes what's happening with the carbon footprint of health systems. And almost everywhere in the world, it's going up. In the US, it's 12% of the carbon footprint of the US. It's clearly crazy that it's going up when it needs to be going rapidly down, as we're talking about here. So I'm the chair of the UK Health Alliance on Climate Change, which probably most people have never heard of, but actually it's existed for some 8 years. It brings together all the major medical and health bodies in Britain, the Royal College of Nursing, physicians, surgeons, anaesthetists, the colleges based in Glasgow, the BMA, the Lancet, the BMJ. And our members between them have some 900,000 members, which is most of the NHS workforce. And it used to be that we had to work quite hard to persuade people to join. Now we have people coming to us. So we've had 8 to 10 new members in the last year or so. People are really waking up to this problem and recognizing that healthcare has to do something and has to be part of the solution. And also that, as you're saying, it's part of the problem. And 3 things I think we can do by coming together. One is we can speak more loudly with one voice. We can go to governments and say, look, this is 900,000 health professionals talking to you. Some of the most trusted people in the community. As we know, nurses are even more trusted than doctors. Secondly, we can all learn from each other. So our different members are at different stages. Because just like the health system needs to get to net zero, they need to get to net zero as well. And some of them are doing pretty well. They've disinvested from fossil fuels. They're investing in renewables. They're cutting their travel. They're changing their canteens. They're having more meetings online. Others are some way behind. So those who are moving fast can help those that are moving more slowly. And then lastly, and perhaps most importantly and relevant to this, if you're going to get surgeons to change the way they practice surgery, who better to do that than other surgeons? It's going to be much less likely that bureaucrats in some skyscraper somewhere are going to influence surgeons. So we've established a working party, which you, Mood, are going to share. Chantelle is going to be part of it. It includes all the surgical colleges in Britain, the anaesthetists, the nurses, the obstetricians, the dentists, the vets. So between us, we cover most of the surgery in Britain. So when you and Chantelle, and we've got funding for this, luckily, come up with a brilliant plan, we can go to surgeons and say, look, here's a formula for what you need to do. And as regards barrier, I suppose our biggest barrier is lack of resources. We have only 1.6 employees. We could potentially employ 50 people and do real good, I think.
Thank you, Richard. That's great. I mean, I'm very happy that you've put it on record that I'm going to create a brilliant plan that all surgeons are going to. You have great confidence in my abilities. So it's great that we work together. And I think what we also recognize, and of course, you know this more than anybody, is that health systems around the world are actually very different and how they're structured and funded. So in the UK, we are quite privileged that the majority of healthcare is state provided, although there is not an insubstantial private provision. But in many countries around the world, healthcare is privatized or increasingly privatized, even in low resource settings. We're seeing privatization of healthcare, and fundamental difficulty where, let's be honest, there is sometimes a tendency towards over-investigation and over-treatment where profit can become a motive. So how can we bring other healthcare systems, particularly those that have got a private sector influence, into this conversation?
Well, I mean, I would suggest that each country needs a network like ours, and that should include private players. I mean, we have debated whether we should do that, whether we should include pharmaceutical companies and others as members of our alliance. And so far we haven't. We've concentrated on health professionals, organizations of health professionals, because we think it gives us a particularly privileged voice. But at the same time, we're very interested to work with private sector organizations. I spoke the other day at a conference organized by WBA, which for me means West Bromwich Albion, but actually is Walgreens Boots Alliance. And they, have a huge coverage. We have to work with it. And I don't agree with your implication that if something is for profit, that means it doesn't mean that you can get to net zero. For-profit companies are going to have to do that as well. And in fact, I chair a small for-profit company of about 70 people called Patients Know Best. We do everything digitally. We don't have an office. We never have had an office. We measure our carbon footprint and we constantly work to reduce it. So I don't think there's any incompatibility between being for profit and reducing your carbon footprint. In fact, as I said at the beginning, most health systems, many of which are publicly funded, have rising footprints, whereas I think most companies, not least because one of the immediate benefits of reducing your carbon footprint is that usually you reduce your costs. And if you're about profit, then you're very, very interested in your costs, because there's no better way to increase your profits than reduce your costs.
Thank you, Richard. Yes, I guess there's always that the balance between when you're delivering the healthcare, you want that as low as possible, but you want more healthcare because that is the bread and butter of how, for example, you will make your money. The carbon footprint of the US is 12%, so that would suggest there is certainly a balance there. I mean, there's been a few questions in the chat, so it would be good to sort of bring out some of those ideas. I know there's been some question about whether we should be carbon footprinting products, and that seems a good principle, but Chantelle, maybe I can come to you. I mean, how would we realistically achieve that? Is that achievable? Are we going to get honest, real data on this? Just your thoughts about the technical aspects of doing such a maneuver.
Hi, Mead. Can you just clarify, was that in relation to industry and looking at the supply chain carbon footprint?
Yes,
so
exactly. So there were some questions about whether companies should be providing their carbon footprint, and that should be a metric on which we make some of our purchasing decisions.
It's really complex. We certainly need greater transparency from our partners and colleagues in healthcare industry, and we need to then have the information such that we're able to, in an open way, evaluate their underpinning processes, for example, in terms of the amount, the extent to which they actually use air freight within the supply chain. In terms of carbon footprinting and expectations on industry to actually do that, it's something that's very complex, and it's something that is subject to manipulation, essentially. So I think we're going to have to be very careful in terms of the way that we engage with industry, such that we are able to develop those metrics that are actually meaningful and that actually help us to make decisions in terms of our procurement. So I think it's certainly a challenging area and something that we're going to have to address in the coming years.
Thanks, Chantelle. I mean, Fiona, do you have any thoughts on this as well?
Well, I mean, I think it's just that we're at a different stage of measuring environmental impact. I mean, can you imagine producing a product where you didn't know how much it was going to cost you to manufacture it? That's just part of what we do, in the same way as when we now develop any healthcare intervention, we think about health outcomes. That wasn't true half a century ago. We could change it so that environmental impact just becomes part of how we assess what we do. And that's, I think, we need to challenge our thinking. We might be at a different stage, but we need to just make it an integral part. We don't need to make measurement a nightmare in terms of complexity, but we do need to make it part, because that's the only way we're going to change impact.
Thanks. And Cassie, perhaps I can come to you. I mean, one of the questions we've also had, I mean, Richard Newton, I know, has put on the chat, but the idea of infection control and this idea that we have to have a lot of single-use product and a lot of products. I mean, I'll be honest, I go crazy about the gloves that are used, for example, in a hospital. And although this is not the forum, I could talk to you about the endemic forced labor in Malaysia that has been created by our penchant for using billions of single-use gloves at the lowest possible price, as well as all the environmental harms. But there are lots and lots of things about infection control. Is that actually a concern, or is the learning, for example, from India and from your own work, that actually those two things are not discordant?
I don't think that you need to have disposables to have good infection control practices. Of course, because we're here in the US, for example, really geared around disposable equipment, it will take some shifts in process and in behavior to get used to not throwing everything away every single time you use it or not use it. But we definitely see in other settings that it's not, these things don't go hand in hand necessarily. So we can definitely design better systems. We should definitely try to do so, because it's really not sustainable to have to constantly be buying brand new disposable items every single time. And as we saw through the pandemic, it's really not a great strategy for resilience either, that we depend heavily on these global supply chains that have cracks in them, and climate change itself will cause issues and disruptions in our supply chain. So we'd be better off diversifying into more reusable products. The reusable products have to be designed for reuse. So we have seen some issues with endoscopes, for example, not being designed well for cleaning. So those are other aspects that need to be considered when looking at infection control. But we could certainly use more infection control people working on these sustainability issues.
Thank you, and that's certainly a discussion I'm trying to have. And I think, again, the learnings from India are fantastic, both in terms of infection control, but also bringing the production of products close to home, so that we can actually control this and bring economies of scale that we would dream of now in high income countries. So I think it'd be great to, I think it's time that we need to finish this session. I want to thank all of our speakers for a very broad and engaging discussion. It's clear that we need lots and lots of different aspects to this. We need industry, we need leaders, we need education, we need research, and we need collaboration to make all of this work. And I encourage all of us, in fact, I've been really enthused over the last several months at how much this is gaining traction and how people are talking about this. So please let us all continue, and let's make healthcare a leader in this field, because this is as much as a climate crisis as it is a health crisis. So thank you all also to our audience for listening in, and thank you again. Goodbye.
Thank you.